Gender is a critical element depending on the disease that we are considering. Again, if we talk about extremes, for example, gout is much more common in men than it is in women, whereas lupus is 10 times more common in women than it is in men. We don't really yet understand that, although I think one of the hypotheses, perhaps a little bit simplistic, has been that it's due to hormonal differences across men and women. That hasn't been well established. And many years ago, there were studies on hormonal manipulation as a manner of addressing therapy for women who had lupus. The other thing about, I think, gender differences is that it is not always what it seems. As an example of that, if we look at axial spondyloarthritis, which is inflammatory disease that predominantly affects the axial skeleton, we've now divided that into really two categories: radiographic axial spondyloarthritis, or ankylosing spondylitis, and non-radiographic axial spondyloarthritis. And that is when we don't have X-ray changes, but either have just MRI changes, or patients who are HLA-B27 positive and have features of spondyloarthritis. And we used to think that ankylosing spondylitis was predominantly a disease of men. However, as we've now redefined this group of diseases into axial spondyloarthritis, we're learning that non-radiographic axial spondyloarthritis, which is in this same spectrum, may be slightly more common in women than it is in men. So gender differences exist. They're not yet well explained, and they're not static. I think this example of axial spondyloarthritis, where non-radiographic axial disease is more common in women than it is in men, is an example where our view of this whole group of diseases is changing. And that sometimes has been a challenge because older physicians, of which I guess I'm one now, used to think that ankylosing spondylitis was predominantly a disease of men, and it isn't. I mean, this group of diseases are at least as common in women. I think quality of life has become an increasing interest in terms of treatment for the management of rheumatic diseases, because it was such a challenge in the past. When I started in rheumatology, which was 34 years ago now, about 50% of patients who had rheumatoid arthritis were disabled within 5 years of developing the disease, which is an enormous burden on quality of life. That doesn't happen anymore because our therapy is so much better. But nonetheless, we do well understand that quality of life is a critical element in a patient's normal life. And it's not something that we had the capacity to modify in the past, but we do now, because the new therapies that we have impact on quality of life. And therefore, we become much more critical in terms of measuring quality of life in patients who have rheumatic diseases and who are being treated. There are outcome measures such as the Health Assessment Questionnaire, the HAQ, or the PROMIS questionnaires that are very specific, targeting quality of life measures. So I would conclude by saying that quality of life is impacted by rheumatic diseases. We now have the capacity to measure that, and importantly, we have therapies that very much have influenced quality of life measures in our patients.